We welcome you all to the next episode of the Checkup Tête-à-tête. In this edition, we have brought to you an interview with Dr. Saratchandra, Professor of Neurosurgery at AIIMS, Delhi. Dr. Chandra specializes in epileptic surgery and is also the in charge of the Center for Excellence for Difficult to Treat Epilepsy, being commissioned as a national facility under the Ministry of Science and Technology of the Government of India. Today, he is in conversation with Yash Kamath, a third year student at St. GS Medical College and KM Hospital, Mumbai, and an active member of the Checkup's editorial team. We thank Yash for making this enlightening interview with Dr. Saratchandra possible.
Hello everyone, I'm Yash Kamath. I'm a medical writer at the Checkup magazine. Today, we are talking with Dr. P Saratchandra, who is professor and head of unit Department of Neurosurgery at AIIMS Delhi, and is the team leader for the Center of Excellence for Epilepsy at AIIMS. In view of the National Epilepsy Day on November 21st, he will be talking to us about epilepsy, its treatment, and his experience in the field with epilepsy surgery. Good evening, sir.
Good evening, Dr. Kamath. It's a pleasure to be with you on this portal.
Thank you, sir. So, for those who are new to the medical stream and for the general public, could you introduce to them what epilepsy is and what you would do within that field?
So, epilepsy is nothing but an outburst of a group of neurons within the brain. So, for the layperson to understand, whatever we do, whatever we think, whatever manner we interact with the world is because of the activity of neurons. And the neuronal activity is exactly the same as that passes, it's like an electricity which passes through a mobile device. And that's how the neurons interact with each other. And that's what produces the human behavior. So when we have a bunch of neurons which have gone rogue, that is what generates a seizure. And if this bunch of neurons goes rogue, over a period of time continuously, that is what we call it as epilepsy. So seizure is a single event which can happen to anybody, provided we bring that person to that particular situation. So if we are able to reduce the threshold to produce of the neurons to a certain extent, that it will cause seizure in anybody. So for instance, if I were to pass, some kind of an electroconvulsive therapy to you, you would also develop a seizure. Or somebody, goes into a state of hypoglycemia, they also can develop a seizure. Or somebody does not sleep for 24 hours, 48 hours, or they are hungry completely, that also can produce a seizure. But when a person develops seizures over a period of time because of the brain becoming susceptible to produce seizures continuously, that is when we say that this person has got epilepsy. So that is fundamentally the difference between seizure and epilepsy.
Thank you, sir. I'm very sure people will be able to now be on the same page for the rest. As we know that as medical students, we mostly learn medicinal treatment of epilepsy, like the pharmacological treatment. So, what prompted you to think of a surgical intervention for epilepsy?
So that's a very important question. So one has to understand that surgery for epilepsy is not at all uncommon. It is not something which one would advise as a last resort. And this message has to go crystal clear to all the general physicians or practicing physicians, to everybody. So what one has to understand that unlike antibiotic resistance, drug resistant epilepsy is something which is de novo, which means if you take about 100 people who have epilepsy, 75 of them will respond to medical treatment. 25% of them will have the neurons structured in such a way so that they are completely resistant to medical treatment. And this has been shown by very good studies, very good established class 1 evidence. So if a person does not respond to the first anti-epileptic drug, which is the best possible which is a proper anti-epileptic drug given in its proper dose, then we say that the chance of this person developing drug-resistant epilepsy is almost 50%. If he doesn't respond to two anti-epileptic drugs given in the right dosage and combination for a good period of time, then we say that this person has almost 75 to 80% chance of developing drug-resistant epilepsy. And not responding to three drugs is almost 100% chance that this person has got drug-resistant epilepsy. But before we label a person having drug-resistant epilepsy, it's very important for us to rule out pseudo-refractory causes of epilepsy. For instance, we have to ensure that the person is taking medicines properly. Most of the people in our country do not take medicines regularly, and it's very difficult. I don't blame them, because people with epilepsy have to take the drugs exactly on that time, and many of them, they forget to take the medicines on that particular time, that again leads to a pseudo refractory seizures. Similarly, proper medical treatment should be given. Often, patients are given homeopathic doses of anti-epileptic drugs, or they're kept on polytherapy for 4 or 5 drugs, which should be discouraged. The strategy should be that you start with one anti-epileptic drug, increase it to its maximum dosage, and if the person is not responding to that, you have to combine a second drug which is completely compatible with it in terms of its pharmacokinetics and its dosage. And for this reason, one has to consult an expert neurologist so that this proper combination can be given. Now, while this takes care of 75% of the cases, 25% of them are not going to respond to medical treatment. So these are the patients who would be called as a drug-resistant epilepsy. And these are the patients where we look at surgical options, because surgical options as of today is a very, very good option. I would say it's a very, very encouraging option.
Okay, sir. So as you pointed out, compliance, patient compliance, and a proper regimen for the dosage and drugs should be followed. So with that, we'll cover most of the patients. So for these 25% patients, could you explain how the epilepsy surgery works? Like what is the aim of the surgery and what are the outcomes, possible outcomes?
See, today when we talk about epilepsy, we don't call it as an epileptogenic focus, because technically speaking, there is nothing like generalized epilepsy. So technically speaking, epilepsy arises always from a specific area of the brain, but in some patients it can spread so fast so that it looks like generalized epilepsy. So today when we talk about epileptogenic focus or epileptogenic zone, we don't call it as a focus or a zone. We prefer to call it as networks. So there are a bunch of networks of neurons which have gone rogue, which are firing seizures, and that's what leads to drug resistant epilepsy, because they cannot be controlled by drugs. Now, when we say networks, with this we mean three things. A, it could be multiple, which means it need not be just one group of neurons. So there could be a bunch of neurons in the frontal lobe, or there could be a bunch of neurons in the temporal lobe. So it's a network of neurons which are connected to each other. B, these are dynamic, which means that if we do not treat the person as early as possible, so once the diagnosis of drug resistant epilepsy is done, the person should be treated as early as possible, because if you wait, these networks are going to become more complex and they're going to expand. So if you offer them therapy, let us say after surgical therapy, let us say after 10 years, then your outcomes are going to be much, much inferior than what it would have been if you had offered them 10 years earlier. Okay. And number three, these networks need not be close to the lesion. So it doesn't mean that on MRI, if you do not see a lesion, this person cannot undergo epilepsy surgery. That's a big misnomer. At the same time, if you find a lesion, it doesn't mean that all the networks are there at that particular lesion only. So we have to define where exactly are the networks, and if the lesion is present, what is the relationship to the lesion. So usually it is close to the lesion, but nowadays we find very complex cases where it could be away from the lesion. So these are the three things which have to be established before we think of surgical therapy. Now, surgical therapy could be basically three types. So one is called as a resective surgery, whereby we resect out the lesion as well as the bunch of networks around it. So we resect it out completely. So this is called as a resective surgery. Or it could be disconnective, whereby we disconnect it from the rest of the area. Or we could offer some kind of neuromodulation. Now, unless people should go with an idea that neuromodulation in epilepsy is not at all as effective as it is for deep brain stimulation for Parkinson's or any other movement disorders. It is to be considered only when we do not have a proper option for resective or for disconnective surgery. So giving some examples of resective surgery, the commonest example is you can do an anterior temporal lobectomy with amygdalohypocampectomy, or we can do a lesionectomy if you find a focal cortical dysplasia. Or there are certain tumor-like malformations like dysembryonic neuroepithelial tumor. They are benign tumors which do not grow but keep on producing seizures. So then in that case, you need to do a lesional excision plus the excision of the networks around them. And plus in some cases, you need to do a complete lobectomy. You may need to do a frontal lobectomy or for a temporal lobectomy where the networks are much more diffuse. So these are few examples of a resective surgery. Now, disconnective surgery, this is again more for medical persons. It could be interhemispheric disconnective surgery. So where you could do a corpus callosotomy or a commissurotomy, or you could even do an hemispherotomy where you disconnect the entire hemisphere from the rest of the brain. or it could be intrahemispheric, like multiple subpile transections. So, whereby you produce multiple cuts on the cortical surface so that you have a seizure focus arising, so they are limited only to those area between the cuts. Uh, So, these are the examples of disconnective surgery. So, in cases where we do not have localization, we can use neuromodulation like vagal nerve stimulation, which is the commonest used neuromodulatory procedure. It has been done, more than in 2 lakh cases, 200,000 cases all over the world, where we attach a generator, leads to the left vagus nerve. But we have to understand that the neuromodulation or vagus nerve stimulation or any other neuromodulatory procedure should be treated as if we are adding a second drug or a third drug or a fourth drug. So it's as if we are adding another drug. It should not be treated like surgery. So let us say you have exhausted all the drugs and you don't have any localization. So you do a VNS, it is as if you added a fourth or a fifth drug. So it produces an overall benefit of reduction of seizures by 50% in 50% of cases. So if we have 100 people, so in 50 patients, it can reduce the seizure burden by 50%. Whereas receptive surgery can be very effective. It can lead to seizure freedom in 70, 80, 90% of the cases, depending on the pathology. Similarly, the disconnective procedure again also can be very, very effective. For instance, hemispherotomy can be as effective as 80, 90%. It's one of the most effective surgeries. So again, surgery is an umbrella term. There are various different surgical strategies, and this has to be discussed in the comprehensive epilepsy team, which is a multi team approach. You have the neurologist there, you have the nuclear medicine, you have the neuroradiologist, you have the clinical psychologist, and we present these cases there. And then finally, we take a decision of A, whether the surgery should be done, B, what is the type of surgery which is to be done, C, what is the amount of neurological function restoration we are looking at, D, what is the outcome of the surgery we are looking at. So these are the decisions which we take in the comprehensive epilepsy surgery meeting, and that is when we go ahead with surgery. Now, in some complex cases, despite doing all the investigations, we are not able to find any networks. So in those cases, nowadays, using a robotic system, we insert thin electrodes into the brain. We call it as stereoencephalography. So we can put multiple electrodes, and then once we put electrode, then we do recording for another 4, 5, 6, 7 days. We localize where the spontaneous seizures are coming out from. We also stimulate the electrodes in order to produce habitual seizures. Okay. And once that double confirms our hypothesis, and then as a second stage, we go in and do the surgery. So this in ballpark is the gross method by which we approach persons with drug-resistant epilepsy through the surgical methods.
I'm very sure that this will be very informative for medicine and surgery students right now. Like you said that once we detect that there is a drug resistant epilepsy and we should treat it, like I'm understanding that we could treat it like a drug resistant infection also. Like we need to look for an alternative treatment immediately. So
Yes, but there is a big difference, and that is what I like to emphasize. When we say antibiotic resistance,
yeah.
it gives an idea that you have given a bunch of antibiotics, the person has now become resistant to antibiotics
Oh,
because you have administered those antibiotics to the patient. In drug resistant epilepsy, the person is drug resistant from day one itself.
okay.
And by giving 1, 2, or 3 drugs, you're discovering that this person is drug resistant. So you should not wait for several years before you come to a decision that this person has got drug resistant epilepsy. The danger is today, as of today, we have over 2 dozen or 3 dozen anti epileptic drugs available. So every time a person goes to a general practitioner and this person starts a new anti epileptic drug, so this patient will have a honeymoon period of about 6 months, after which the patient is going to have a breakthrough seizures. Okay.
Yeah.
Yeah, so the general practitioner could go on experimenting newer and newer drugs, and this could go on for 10 years before finally you say that the drugs are not working. But there is enough evidence to show that drug resistant epilepsy can be immediately diagnosed moment you see that the person has not responded to 3 anti epileptic drugs given in the proper dosage and proper duration and the proper combination.
Yeah.
For instance, if you combine carbamazepine with phenytoin, that's a horrible combination. So you should know what type of drug. So an intelligent combination of neuropharmacy is very, very important. So that's the reason if a person doesn't respond to epilepsy with first drug, that this patient should be immediately referred to a neurologist, particularly specializing with epilepsy, so that they can diagnose the epilepsy condition and they can provide an intelligent neuropharmacological combination. In addition, there are also other alternatives like ketogenic diet.
Acha.
So a center which is specialized in epilepsy surgery, they will know how to optimize the medical treatment for epilepsy in cases who are not controlled with one anti-epileptic drug. And once you're sure that even with 3 drugs they're not getting controlled, the duration for this should not be more than 3 to 4 years. Now, International League Against Epilepsy says that for a period of 1 year, if the seizures are not controlled, it should be diagnosed as a case of drug-resistant epilepsy. But in practice, we find that patients have been waiting for 10 years, 15 years. So that should not be there. Because if you wait for long, what happens? There is loss of neuronal function. So person has epileptic encephalopathy. So the cognitive functions rapidly deteriorates. B, you are kind of making the networks much more complex because the networks are dynamic. They're going on expanding over a period of time. So the more you wait, the less successful is the surgical treatment going to be for that patient. So that is the reason you should make the diagnosis of drug-resistant epilepsy as early as possible. Okay. And for the practical purposes of all general practitioners, moment you see that the person is having a breakthrough epilepsy, after giving him monotherapy in full dosage, that is when this patient should be immediately referred to a neurologist. But normally what we do is general practitioners, they give homeopathic doses of, let us say, carbamazepine. Then it is not controlled, then they will start on homeopathic doses of levetiracetam. It is not controlled, then they will start on some other drug. And this kind of experimenting which goes on, and this kind of experimenting should be strictly avoided for the benefit of the patient.
So, as you said, that once we get the diagnosis done, we should immediately proceed to the next step. So that would be one of the 3 types of surgeries, 2 types of surgeries, and that one additional medicine sort of treatment that you mentioned, vagal nerve stimulation. Yeah. So, in practice, apart from your center, which is specializing in this, what do you think about the current situation regarding epilepsy surgery in India? Are we following this procedure properly or not?
See, there is a lot which needs to be done for epilepsy. In India, at a ballpark figure, which is an extrapolated statistics, at any given point of time, we have about 10 million people who are suffering from epilepsy. Out of this, even if 25% of them have drug resistant epilepsy, that would be close to 2 to 2.5 million people who would be having drug resistant epilepsy. To this, another 1 to 2 lakh patients would be added every year. So a rough estimate by the International League Against Epilepsy, of which I am also one of the members, has shown that India needs at least 600 centers if it were to tackle or if it were to just take care of the current load of
Existing
persons with
cases.
drug-resistant epilepsy. But the problem is our level of awareness is very, very less. So when we started a comprehensive epilepsy surgery program at All India Institute in 1996, initially we found very few number of referrals because people were afraid of surgeries. So after having operated more than 2000 cases, now we find that there is a tremendous waiting list. So there are patients who have this complex pathologies who keep on coming to our centers. And now they have seen their relatives, they have heard from the word of mouth that following epilepsy surgery, your outcomes are very good. But again, this is a complete art. This is a complete science by itself. So you need a lot of training. So we have developed a clinical fellowship. We have a research fellowship. So we have a research arm. So a lot of these things have to be inculcated into the system. It's not just that you start an epilepsy surgery program. There is a lot of training which goes into it. There is a lot of skill acquisition which goes into it. There is a generation of people who have to become used on how to take decisions. It's not just taking every patient has to be individualized. It's not like doing some kind of an hernia or hydrocele. My apologies if I'm trying to compare it with that. I know every pathology is important, but every case is unique, and you need to take a lot of decisions for every case. So you see, this is MRI finding, this is a PET finding, this is a SPECT finding. So what should we do? Should we do an invasive EEG? Should we do an SCEG? Shall we do magnetoencephalography? Should we try drugs? So it requires a lot of thinking, a lot of cerebral work before we decide for surgery. So it's not that, it's not like so straightforward that you say one, two, three, and then okay, we do surgery. It doesn't happen like that. And for the same reason, this kind of knowledge base has to be created, and it doesn't come in one day. So I would say that we need to develop more epilepsy surgery centers in our country. Now, saying this, we have published a very widely cited paper where we described how to set up the epilepsy surgery centers in India. So we could have a level 1 center, we could have a level 2 center. So level 2 center is a tertiary center where more complex cases can be referred. For doing a level 1 center, you don't need so much of equipment. Okay, you need to have an MRI, need to have a dedicated neurologist who has a video EEG machine, and you have the usual operative setup, and then you'll be able to do most of the basic epilepsy surgeries. For more complex cases, you may require more advanced investigations, which could be there in the tertiary center. So there is a lot which needs to be done. And I would say that it is not a rare disease at all. We have lots and lots of patients. The only thing is we need to create this awareness that this kind of facility can be created, and it could be very, very beneficial for this group of patients.
So, as students, we are mostly exposed to like these common cases which we find in our OPDs or wards. So I don't think mostly patients find like students find epilepsy cases or anything. We mostly see that like after a head trauma or anything like that. So in that point of view, so do you think in the future we should focus more towards a medical treatment or a surgical treatment for epilepsy?
See, both of them have their roles. The medical treatment can maximally treat 75% of the patients. So it's predominantly a medical disease. There will be 25% of the patients who will not respond to medical treatment. They have to be sent to tertiary centers. Over there, the neurologist will optimize the drug treatment. They will try ketogenic diet. They will do some other tests. And then they will take a decision whether this patient has to go for surgery. Now, despite doing that, we will have at least 2 million cases in this country who will benefit from surgery. So you're right. Even I did not see a single case of epilepsy surgery when I underwent neurosurgical training. But now we have an epilepsy surgery and functional fellowships programs, and our fellows see at least 2 to 3 cases every week, and they're all very, very complex cases. Now, when they see that, they get complete information and confidence on how to manage these cases of epilepsy surgery. Now, if they go outside and set up these centers, in other big hospitals, they will start getting patients. So this I would I don't know if you've read that book. It's called as a Blue Ocean Strategy. Have you read that book?
Yeah, you had recommended it. I did go through it.
So you should read that book because these are new areas.
Yeah.
So when people do, when you do a neurosurgical residency, you'll have so many options where you can subspecialize. You'll have skull base, you'll have spine surgery, you'll have pediatrics, you have traumatology. So epilepsy and functional is a new area, relatively growing area. And anybody wants to concentrate on that, there is a huge scope for this. So if people diversify into new areas, they will be able to produce, they will be able to give more service to the patients who cannot have access to this kind of healthcare. That's A. B, you will be developing new skill sets which will be useful for your next generation to come. Otherwise, you will not be in a position to develop the new skill sets. If you keep on sticking to the same thing, you're not going to develop new skill sets. So these are important. These are all important components as the medical field expands. And in our country, there is a tremendous scope and a tremendous need for this subspecialty. And again, I reiterate and I underline this. It is not an uncommon subspecialty at all. At one point of time, we used to think that subarachnoid hemorrhage is very, very rare in India. But now we find it so commonly. Similarly, drug-resistant epilepsy is also very, very common. We just don't see those cases because these patients don't come to the hospitals. Most of them end up going to quacks or they end up going to GPs and they keep on getting added newer anti-epileptic drugs. They're on drugs for many years. They don't respond. They keep on having seizures day in and day out, and they think that there is no option for this group of patients. Okay, but that is not true. So these they should be referred to a tertiary center, and the seizures can be completely cured. Let me tell you one thing. Among all the I have operated over 25,000 cases. Among all the subspecialties, I have found the maximum sense of satisfaction coming from patients who have been operated for drug resistant epilepsy. So you treat a patient, he becomes seizure free, you're treating the whole family.
Yes.
And these patients who are usually young in their age, they're able to get back to the work, and the whole family. Otherwise, when the person is having seizures, the whole family is disrupted. The parents are disrupted, the spouses are disrupted, the children are disrupted, or everything is disrupted completely. But moment your seizure stops, then the family can heave a sigh of relief. Then they can start going along on the normal
Path.
path of life.
So, like you said, like parents and relatives and all can be finally satisfied that their treatment has worked, and then the quality of life can gradually improve. So, is it possible that there is some superstitious association with seeking treatment in epilepsy, like the way it presents, and maybe some religious or superstitious association that people will feel like maybe we should not seek treatment for this? Have you ever encountered anyone like that?
See, that is a very good point you brought out. One of the unfortunate things with epilepsy is the stigma behind epilepsy. And this is what leads to the treatment gap. So, the treatment gap is the gap between the number of patients who require treatment versus the number of patients who are being provided treatment. And the treatment gap for epilepsy is one of the highest as compared to any other disease. A person who's got blood pressure, there's absolutely no stigma. A person who's got diabetes, there is no stigma. A person, even he has tuberculosis, there is no stigma. But moment is epilepsy, nobody wants to disclose, especially if it's a girl. Nobody wants to tell anybody that this girl has got epilepsy. We get children, marriageable age girls. They come for surgery when a girl becomes marriageable because they want the seizures to be controlled. So it's so unfortunate. They come, they do the surgery, they say, "Abhi shadi ho jayega." Then they go back. When they grow the hair, they still take, they're seizure free. But the spouses many times are not told. They're not disclosed that this person has undergone surgery. So there's so much of stigma associated with epilepsy, which is unfortunate. So people think that epilepsy is very closely related to lunacy. It is very closely related to madness. It is not. It is a disease like any other disease, which is completely curable with medicines. And if it is not curable with medicines, there are very good surgical options. Okay. There is a picture from the International League Against Epilepsy which says epilepsy out of shadows. It means it's time for us to bring epilepsy out of shadows, out of the superstitions that is surrounding it, out of the stigma that surrounds this condition. And this is the reason we do not call a person with epilepsy as an epileptic. It is kind of looking down upon that person if you call him epileptic. Or we do not call a person with epilepsy as a patient. We just call them as a person with epilepsy. Okay. And if you look in the history, we have had some really great people, very, very famous people who had epilepsy came out of it, and they have done very well.
Yes. Yeah.
In fact, Julius Caesar
Yeah.
was said to have epilepsy. There are so many other famous people who were said to have epilepsy, but they have come and they have done very well. If you get the proper treatment.
Yeah. Actually, that Julius Caesar fact I had read like just 5 6 days ago. I made a Instagram post about it. So I was just going on to that point. So we have to basically change the worldview from disability to person with problem, which can be treated. So that's the same thing like we see with mental health issues as well. Like people are viewed as disabled or like unable to comply with life or anything. But we just have to change the perspective towards the disease. I think that's what
Absolutely.
you're getting at.
Absolutely.
And I think with the informative session that you have given right now, people will be more aware of what treatment modalities exist for epilepsy. So I'd like to thank you, sir, for your time and for all the knowledge that you have given us. We'd be happy to have you anytime later if you would be interested in any other thing. That's
So thank you very much, Dr. Kamath, and I wish your forum all the best. And I hope that this forum has the ability to reach out to as many people as possible and is able to accomplish the objective for which it has been created for.
it. Thank you, sir.
Thank you. Thank you very much.
Until next time, with another Tête-à-tête by the Checkup. See you guys soon.